Dear attendees, we are delighted to extend a warm welcome to all of you for this online learning event focused on the importance of impact of nurse-led heart failure clinics. So we have the honor of hosting Mr. Subin, who is a distinguished heart failure nurse specialist from All India Institute of Medical Sciences, New Delhi. Mr. Subin brings a wealth of experience and expertise in the field of heart failure nursing care. With his extensive knowledge and dedication, he has made significant contribution in the field of heart failure nursing clinics. He has revolutionized the patient care and outcomes. We are fortunate to have him join us today as a speaker for this session, where he will share his insights and shed light on the profound impact of nurse-led intervention in heart failure clinics. During his talk, Mr. Subin will delve into the importance of comprehensive approach to heart failure care, emphasizing the pivotal role of nurses in delivering the patient-centered services. So he will discuss the nurse-led clinics, how they have become instrumental in bridging the gaps between the healthcare delivery and how to improve the patient education, medication adherence, and thus the overall quality of life for the heart failure patients. We invite all healthcare professionals, clinicians, researchers, and individuals interested in the field to attend the enlightening session. It will be an excellent opportunity to gain valuable knowledge, engage in discussions, and improve and explore the innovative strategies for optimizing heart failure care. Thank you for your continued support, and we eagerly anticipate your active presence in this event. Let us come together to further enhance our understanding of nurse-led heart failure clinics and their profound impact on patient care. Over to you, Mr. Subin. Thank you.
For give me an opportunity to present my topic of heart failure and heart failure nurses in Indian Society of Emergency and Cardiac Society. So now, first of all, I will discuss about the heart failure. Then I will go into the heart failure nurses. So heart failure, we know, before going into the heart failure, I wanted to go into the history. So in ancient belief, they believed that all the diseases are coming from the overburdens of the blood. So what they did when they had any disease is they do bloodletting. They let the blood out of their body. So they do it by making a cut in their body, and they make the blood flow out of the body. Then comes the leeching therapy. So here they put the leeches in their body and they made the leeches to suck out their blood. Then comes the Hippocrates era. He's the father of modern medicine, and he discovered the structure of heart, anatomy of heart. He discovered the structure, or like four chambers, valves, that all he discovered. Then the concept of this treatment has been changed. Then in 1628, William Harvey discovered the circulation. He discovered about the venous blood and arterial blood and all. Then in 1785, William Withering published the medical use of digitalis. Digitalis, we know that is a drug which is obtained from the dried leaves of common foxglove, that is known as digitalis purpura. Then in 1819, René Laennec, he invented the stethoscope. So that is a big invention to hear the heart sound. And in 1895, William Röntgen, he discovered the X-rays. So this improved the diagnostic ability. Then in the early 20th centuries, there was sooty tubes. These sooty tubes, they used to treat the heart failure by pricking into the body. They prick these tubes into the body, into the peripheries, and they drain the blood out. The extravasation fluid they taken out. In 1920s, organomercurial diuretics are first used, And in 1954, Inch Edler and Helmut Hertz used the ultrasound to image the cardiac structures. In 1958, thiazide diuretics were introduced, and in 1967, Christian Bernard he performed the first human heart transplantation. In 1987, the consensus one study shows the unequivocal survival benefit of the angiotensin converting enzyme inhibitors in severe heart failure. So from there onwards, the ACI inhibitors started in the treatment of heart failure. So what is heart failure? Heart failure, we know heart is not able to pump the enough blood and oxygen to meet the body's demands and needs. So in globally, 26 million adults who is affected by heart failure. The prevalence of heart failure in India is ranges from 1.3 to 4.6 million, with an annual incidence of 0.5 to 1.8 million. So according to European Society of Cardiology, 2021 edition, their guidelines, the heart failure is not, the definition of heart failure, they define like it is not a single pathological diagnosis, but it is a clinical syndrome consisting of cardinal symptoms and signs. So it contains symptoms, certain symptoms and signs. What are the symptoms? They are breathlessness, angle swelling, fatigue, etc. And that may be accompanied by the signs. What are the signs? Signs are the objective data, whereas the symptoms are subjective. Sorry, here. So the signs are objective. We can see that like elevated jugular venous pressure, pulmonary clacks, peripheral edema, etc. So it is due to the structural or functional abnormality of the heart. So that result in the elevated intracardiac pressure and or inadequate cardiac output as a result at the rest or during the exercise. This is the definition given by the European Society of Cardiology in 2021 guidelines. So it is a complex syndrome which contains symptoms and signs. It is in the presence of the structural or functional abnormality of the heart and inadequate cardiac output at rest or during exercise. So what are the types of heart failure? You can see the systolic and diastolic heart failures are there. Systolic heart failure is nothing but the heart is not able to pump. Pumping ability of the heart uh, is affected here. Whereas in diastolic heart failure, the filling ability of the heart is affected. So here the heart cannot fill because of these stiff or thick chambers of the heart valves. The systolic failures are most common, and it is the hallmark finding. We can see the less ejection fraction. Left ventricular ejection fraction will be very less. So it is due to impaired contractile function like the MI, increased afterload like the hypertension, then cardiomyopathies, mechanical abnormalities, etc. And diastolic failures are due to impaired ability of the ventricles to relax and fill during the diastole, decreased stroke volume and cardiac output. And diagnosis is based on the presence of the pulmonary congestion and pulmonary hypertension and ventricular hypertrophy. And according to the ejection fraction, we divided this heart failure into three types. That is, ejection fraction is very less. That is heart failure with reduced ejection fraction, and ejection fraction is moderately reduced, and ejection fraction is preserved. So these are the three types. So HF ref, HF MRF, and HF ref. So here you can see the criteria like in reduced ejection fraction, there will be symptoms and signs plus left ventricular ejection fraction will be less than 40%. Whereas in mildly reduced ejection fraction, there will be symptoms and signs plus ejection fraction will be between the 41% to 49%. Whereas in preserved ejection fraction, here there will be signs and symptoms, but the ejection fraction will be greater than or equal to 50%. So that is the difference between a reduced ejection fraction and preserved ejection fraction. Preserved ejection fraction, there will be more than 50%, and reduced ejection fraction, there will be less than 40%. Okay. So this is the question. You will get the link regarding this in your comment box, I think. So here the question is, which of the following is the correct classification of heart failure based on ejection fraction values? Heart failure with reduced ejection fraction, that is EF is less than 50%. Heart failure with preserved ejection fraction, that is EF is greater than 50%. Heart failure with mid-range ejection fraction, that is EF is between 30% to 40%, or all of the above, which is the correct answer. You have to answer this in the link. Next is etiology. Etiology, the foremost and important etiology is CAD, coronary artery disease, the ischemic heart diseases. That is the main cause of heart failure. Then again, hypertension, valvular disorders like aortic stenosis, congenital valve disorder diseases, then arrhythmias like atrial tachyarrhythmias, ventricular arrhythmias, then cardiomyopathies like dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathies, then congenital heart diseases like congenitally corrected or repaired transposition of great arteries, TGA, then shunt lesions, then repaired tetralogy of Fallot, then Epstein anomalies, etc. Then the infective reasons like viral myocarditis, post-viral myocarditis will lead to the heart failure. Then infiltrative diseases like amyloidosis or sarcoidosis, etc. These are the examples: CAD, hypertension, valvular disorders, and arrhythmias, CMP, the cardiomyopathies, then congenital heart diseases, infective disorders, drug induced. Drug induced is also important. Drug induced, you can see the chemotherapy drugs, anthracyclines, trastuzumab, like that. The then infiltrative diseases like amyloidosis, sarcoidosis, and neoplasms. Then storage disorders like hematochromatosis, then glycogen storage diseases like. Then endomyocardial disease like radiotherapy, endomyocardial fibrosis, eosinophilia, then pericardial diseases like calcification, infiltrative pericardial diseases, then metabolic disorders like endocrine diseases, especially the thyroid functions, then nutritional disorders like thiamine, vitamin B1, and selenium deficiencies, then autoimmune diseases, then neuromuscular diseases like muscular dystrophy and all. So all these are the reasons for causes and etiology of heart failure. Then the risk factors are, you can see the risk factors like sedentary habits, cigarette smoking, obesity, excessive alcohol intake, influenza, flu infections, then microbes like streptococci, then cardiotoxic drugs like I mentioned before, that chemotherapy drugs, then the chest radiations, then hypertension, dyslipidemia, diabetes mellitus, CAD. These are the risk factors. So now we discussed about the etiology and risk factors. So the question is, which of the following is most common cause of heart failure? Is the most common cause of heart failure? The most common. The options are ischemic heart disease, congenital heart disease, myocarditis, and aortic dissection. Then another question, which of the following is not a risk factor for heart failure? Not a risk factor for heart failure. Hypertension, diabetes mellitus, dyslipidemia, and COPD. Next, moving into the physiology of the heart. Physiology, we know for the normal functioning, normal pumping of the heart, there are four things are essential. First one is contractility of the heart muscle, then preload, afterload, and heart rate. What is contractility of the heart? Contractility is nothing but the ability of the heart muscle to contract. Then preload means the amount of blood which is filling during the end diastole time. That is preload. Then what is afterload? Afterload is the pressure towards which the heart has to press, heart has to pump. So this is the pressure against which the heart has to pump. So like if the blood vessels are very constricted, then the heart has to give more pressure, has to apply more pressure. Then heart rate, the rate of contraction in a minute. So all these four elements are the key components in maintaining the physiology of the pumping. You can see this donkey's analogy here. You can see a donkey is carrying a cart which is full of sandbags. So here, suppose the donkey is the heart. So if the preload, that is the load inside the cart, is more, then the donkey has to exert more. He has to do more work for carrying this cart. And suppose if that way is inclined towards the upside, then it will be very difficult for him to climb. So this is the example of the heart's physiology. Suppose the donkey is a heart, and the heart has to carry more water, the more weight, and the way is not good. So just like that, the heart has to pump the blood. So if the load is high in the heart, then the heart has to pump more. And if the blood vessels are very constricted and if the afterload is very high, then heart has to pump more. So the working capacity of the heart will be limited. So if you work for a long time, 2 hours in a gym, then obviously we will get exhausted. Just like that, if the heart is pumping continuously and if our heart has to exert more work to pump, then the heart muscle will become weakened, and thereby the heart muscle will get weakened and fatigued. That will cause heart failure. So this is the pathophysiology. So now we studied about the physiology, then what is pathophysiology? So if there is any myocardial injury, then that will reduce the cardiac output. Okay, so if the cardiac output is reduced, then what will happen? There will be decreased carotid baroreceptor stimulation, and again decreased renal perfusion, and decreased carotid baroreceptor stimulation. This baroreceptor stimulation will cause the sympathetic nervous system activation, whereas this kidney renal perfusion, if it is reduced, then it will activate the renin-angiotensin-aldosterone mechanism. So if this sympathetic nervous system activated, then there will be increased heart rate and inotropy, increased heart rate. So when the myocardial injury is there, if the heart is not able to pump the enough blood, what will happen? There will be increased heart rate. So already the heart muscle is injured, then again the heart rate will increase. Then again the renin-angiotensin-aldosterone mechanism will be activated again. So that will cause the vasoconstriction. That will increase the afterload again. So here heart rate will increase, again afterload will increase, again. The aldosterone will be produced in renin-angiotensin-aldosterone mechanism. Hope you know what is renin-angiotensin-aldosterone mechanism. I will show you in detail. That is, here you can see a kidney. The kidney, if the blood supply to the kidney is reduced, there will be production of renin that will convert the angiotensinogen, which is in the liver. That renin will convert the angiotensinogen to angiotensin 1. Then angiotensin 1 will be converted into angiotensin 2 by the help of angiotensin converting enzyme, which is produced from the lungs. This angiotensin 2 will again cause the vasoconstriction, and it will stimulate the production of aldosterone from the adrenal gland. So aldosterone will be produced and there will be vasoconstriction. So aldosterone, what it will do? It will increase the sodium and water retention in the body. So what will happen? Aldosterone will produce more water in the body because the water will not go out because there is water and sodium retention. So water will be accumulated in the body. There will be vasoconstriction because of the angiotensin and angiotensin 2. So there will be vasoconstriction that will increase the afterload. Then the sodium and water retention will increase the preload. So preload, afterload will be get increased through the renin, angiotensin, aldosterone mechanism. And again, there will be sympathetic nervous system activation. So that will increase the heart rate. So all these three elements will increase, and that will cause the negative remodeling of the heart, and the heart muscles will become weak because it is working a lot, working hard to pump the blood. So gradually it will become weakened and remodeling will be there. Then the heart failure symptoms will start. What are the signs and symptoms of heart failure? You can see right-sided failure and left-sided failure. Right-sided failure means the right side of the heart is failed. So what will happen if the right side of the heart is failed? What will happen? There will be symptoms of cor pulmonale. So there will be distended jugular veins distended, and there will be accumulation of the fluid in the lower extremities, in the abdomen, and the liver will get enlarged. So peripheral edema, ascites, then weight gain, dependent edema, fatigue, all these will come in the right-sided heart failure. Whereas in the left-sided heart failure, there will be paroxysmal, there will be pumping difficulties. So here the pumping ability will reduce. There is systolic failure. Whereas in right-sided, it will be diastolic failure. So what will happen in left side failure? There will be paroxysmal nocturnal dyspnea, then elevated pulmonary capillary blood pressure, then pulmonary conditions like cough, crackles, wheezing, blood-tinged sputum, tachypnea, etc. Then confusion, orthopnea, tachycardia. Confusion is because of the decreased blood flow to the brain. Then orthopnea, the patient cannot lie down, he has to sit. Then tachycardia, exertional dyspnea. Whenever he works, he will get dyspnea. Then fatigue and cyanosis. So these are the symptoms of left-sided heart failure. You can see the symptoms and signs indifferently. Symptoms are again divided into typical and less typical. Signs are again divided into more specific and less specific. The typical symptoms are breathlessness, orthopnea, paroxysmal nocturnal dyspnea, reduced exercise tolerance, fatigue, tiredness, increased time to recover after exercise, and ankle swelling. Then less typical are nocturnal cough, wheezing, then bloated feeling, loss of appetite, confusion, depression, palpitation, dizziness, syncope, and mentopenia. Then again, signs are more specific and less specific. More specifics are elevated jugular venous pressure, hepatojugular reflex. Then hepatojugular reflex is whenever you press the right upper quadrant of the abdomen, there will be deflection. We can see a reflex in the jugular vein in the neck. Then third heart sounds we can hear, and laterally displaced apical impulse. Then less specific signs are weight gain, weight loss, tissue wasting, tissue aging is otherwise known as cardiac cachexia. Then cardiac murmur, peripheral edema in angles, sacrum, scrotum, etc. Then pulmonary crepitations, reduced air entry to the lung. Then tachycardia, irregular pulse, tachypnea, Kine-Stock respiration. The Kine-Stock respiration is also an important sign. Then hepatomegaly, ascites, cold extremities, oliguria, and narrow pulse pressure. These are the symptoms and signs. Symptoms are typical, less typical. Signs are more specific and less specific. Then Framingham diagnostic criteria for heart failure. The major criteria and minor criteria are the major criteria are acute pulmonary edema, cardiomegaly, hepatojugular reflex, neck vein distension, paroxysmal nocturnal dyspnea and orthopnea, rails, third heart sound, and gallop. Then minor criteria are ankle edema, dyspnea on accession, hepatomegaly, nocturnal cough, pleural effusion, tachycardia. So here the major criteria, if when two major criteria or one major and two minor criteria needs to be met for diagnosing heart failure, either two major criteria or one major and two minor criteria. So this is the Framingham's diagnostic criteria for heart failure. The New York Heart Association heart failure classifications. So this is a functional classification according to the functional capacity of the patient. So here class 1, 2, 3 and 4 is there. So NYHA class 1, NYHA class 2, NYHA class 3, NYHA class 4. So what is NYHA class 1? There will be cardiac disease but no symptoms and no limitation in ordinary physical activity. There is disease but no symptom. Whereas NYHA class 2, it is mild symptoms and slight limitation during ordinary activities. The normal house core activities that will cause mild symptoms like fatigue, he may develop breathing difficulty, breathlessness. So such symptoms will develop during ordinary activity. Then significant limitation in activity due to symptoms, that is NYHA class 3. Okay, whenever he walks, he will develop breathing difficulty. He will develop fatigue. He cannot walk. So such state is known as NYHA class 3. And he will get relieved this by rest. So when he take rest, he will get relieved. Then severe limitation, that is class 4, severe limitation. So here the patient is not able to breathe. Breathing difficulties is there. There will be edema, there will be paroxysmal nocturnal dyspnea, and it cannot relieved with rest. That is NYHA class 4. So even if he is bedridden, he will have this issue. So he may. Next question is, which of the following is not a symptom of heart failure? It is not a symptom of heart failure. Fatigue, orthopnea, radiating chest pain, paroxysmal nocturnal dyspnea. You can answer this in the link provided. And another question, which of the following is not a sign of heart failure? Fourth heart sound, B, ascites, peripheral edema, crackles on lung auscultation. So which of the following is not a sign of heart failure? Fourth heart sound, ascites, peripheral edema, crackles on lung auscultation. Okay, next is diagnosis. Diagnosis are the recommended diagnostic test in all patients with suspected chronic heart failure includes the BNP, beta natriuretic peptide, and NT-proBNP, then 12-lead ECG, transthoracic echocardiography, then chest radiography, routine blood tests like complete CBC, urea, electrolytes, thyroid function, fasting glucose, HbA1c, lipids, iron status, etc. These are the tests which is recommended. Then BNP and NT-proBNP, the values usually if BNP is less than 35, less than or equal, sorry, great. Yeah, BNP is for an ambulatory patient. If it is more than 35, then we can tell he may be heart failure. Then NT-proBNP, if it is more than 125, then he may be in a heart failure. Then if it is a patient like hospitalized or decompensated patient, then this BNP is more than 100, we can say he is in heart failure. Then NT-proBNP more than 300 picograms per ml, that is known as heart failure. Then the chest X-ray, you can see the pulmonary. This is also another diagnostic method to see the basic thing. Like we can see these X-rays. You can see the heart. The area is big, so big. So here it is known as cardiomegaly. The heart becomes big, and you can see the pulmonary congestions in these X-rays. So we can diagnose these heart failure by using a simple X-ray. And which of the following is next question is which of the following is correct statement about NT-proBNP levels in the diagnosis of heart failure? First one is NT-proBNP levels are typically high in patients with heart failure. NT-proBNP levels are typically low in patients with heart failure. NT-proBNP levels are not reliable marker for diagnosing heart failure. NT-proBNP levels are greater than 525 picograms per ml is considered as normal. Which is the correct state? Again, we are going into the ECG. ECG here, a normal ECG makes the diagnosis of heart failure unlikely. And the ECG may reveal the abnormalities like atrial fibrillations, Q waves, LV hypertrophy, and widened QRS complex, left bundle branch block, and right bundle branch blocks. You can see here left ventricular hypertrophy. You can visible here. You can see this V1 and V6. That amplitude of the V1 and V6 is very the R waves amplitude is very high, and it is suggestive of ventricular hypertrophy. And here you can see the right ventricular hypertrophy. Right ventricular hypertrophy. Here you can see the V1 is elevated. V1 R wave is elevated. Here you can see the V1 morphology. Here it is upside down. So here first we have to see the lead 1 and AVF. Here we can see the right axis deviation, and we can see the dominant R wave in V1. So these are the diagnostic criteria for right ventricular hypertrophy. Then atrial fibrillation. Here you can see the atrial fibrillation in here. Yeah, there will be P wave. There is the R waves are not regular, and P waves are generated, and R waves are not regular. This is atrial fibrillation. And LBBB. Here the left bundle branch block. The left bundle branch block, here we can see the V1 is V1, you can see the QRS complex is wider, and in V6 also QRS complex is wider. So that's suggestive of left bundle branch block. And the right bundle branch block, here we can see the V1 is again the V1 is R wave is prominent here. And V6 is in V1 you can see the R wave. R wave is upside down. Usually the R wave in V1 should come like a deflection, negative deflection, but it is, you can see a positive R wave here. and you can see Willem, that M-shaped, the LBBB, RBBB, Willem and Moro. So here V1 there will be M-shaped, and V6 will be W-shaped. So these are the ECG variations. We can see there will be atrial fibrillation, Q waves, left ventricular hypertrophy, widened QRS complex, LBBB and RBBB. These are the common findings we can see in the heart failure. So which of the following ECG findings is most specific for LBBB, left bundle branch block? Widened QRS complex in lead V1, abnormal Q wave in lead V1, and depressed ST segments in lead V1, inverted T waves in lead V1. Next method of diagnosis is echocardiography. Echocardiography, the functions of echo, what is echocardiography? Just like an ultrasound machine, we check the functions of the heart. Here we can diagnose the wall motions, the movement of the cardiac wall, and again the valves, then the flow, if there is any regurgitations, then the ejection fraction, all these things we can diagnose through the echocardiography. Okay, the other methods are the CMR. CMR means MRI, then cardiac MRI. Then these are the recommendations given by the European Society of Cardiology in 2021. This EMR is recommended for assessment of myocardial structure and function in those with poor echocardiogram. And CMR is recommended for the characterization of the myocardial tissue in suspected infiltrative diseases like Fabry disease, inflammatory disease like myocarditis, etc., amyloidosis, sarcoidosis, etc. Then invasive coronary angiography. Invasive coronary angiography. It is recommended in patients with angina despite the pharmacological therapy and symptomatic ventricular arrhythmias. Then non-invasive testing. What are the non-invasive testing like CT angio and all, CT. Then cardiopulmonary exercise testing, stress testing, etc. Cardiopulmonary exercise testing is recommended as part of the evaluation of heart transplantation, and MCS is mechanical circulatory support. Then cardiopulmonary exercise testing should be considered to optimize the prescription of exercise training. Then comes the right heart catheterization. Right heart catheterization is to assess the blood pressure inside the right heart. So that will be evaluated before the heart transplantation and mechanical circulatory support. Then endomyocardial biopsy that is used to diagnose the any infiltrating diseases, any rejections and all. Okay, this is the diagnostic tool, guideline diagnostic algorithm. So if the suspected heart failure is there, we have to assess for risk factors. If the patient is having the risk factors, then symptoms and signs and abnormal ECG. If the patient is having all these things, then we have to go for NT-proBNP and BNP testing. If it is more than 125 NT-proBNP and the BNP is more than 35, then we have to do echocardiography. Then echocardiogram, and there is abnormal findings is noted, then we have to assess the EF. The EF we have to classify which type of heart failure is there. So if it is less than 40 or 41 to 49 or more than 50%. So this we have to classify. So this is the diagnostic measure. In the management of heart failure, mainly the upright position, nitrates, Lasix, oxygen, SE inhibitors. You can see mnemonics unload fast. upright position, nitrates, Lasix, oxygen, SE inhibitors, digoxin, fluids, decrease the fluid, decrease the afterload, sodium restriction, and test like Bg potassium, digoxin level, etc. So according to the ESC guidelines 2021, you can see these are the drugs used. Here are the SE inhibitors. SE inhibitors, you can see captopril, enalapril, lisinopril, ramipril, etc. Then ARNI. ARNI is angiotensin receptor neprilysin inhibitors. They are used like a sacubitril valsartan. So if the patient is getting SE inhibitors, then we have to stop the SE inhibitor and start the ARNI. Then beta blockers like bisoprolol, carvedilol, metoprolol, succinate, and nebivolol. Then mineral receptor and antagonists like epinol and spironolactone. Then sodium glucose SGLT, SGLT2 inhibitors. That is dapagliflozin, then empagliflozin. Then other agents like candesartan, losartan, valsartan, they are the ARBs. Then ivabradine, digoxin, and hydralazine, and isosorbate dinitrate. Then other loop diuretics. Loop diuretics are we know the Lasix and all. Lasix, then Ditor, then soluble guanylate cyclase stimulator like very sigwat. Then digoxin again we already discussed about the digitalis and all. So digoxin we give. Then the question is, which of the following is not a recommended treatment for heart failure? SE inhibitors, beta blockers, calcium channel blockers, aldosterone antagonists. Next is, so the treatment modalities, the drugs used are SE inhibitors, beta blockers, MRI, dapagliflozin, then loop diuretics, etc. That will reduce the LV ejection fraction. These are the class 1 indicators of treatment. And that if the LV ejection fraction is 35% and QRS is more than 130 milliseconds, then we have to opt for ICD. Apart from this tablets, these medications, if the patient is still on LVE ejection fraction less than 35% and QRS is less than 130 milliseconds, then we have to start looking for ICD. If the patient is non-ischemic and ischemic, the we can say ischemic is more opted and non-ischemic is class 2A category. Then again, LV ejection fraction is 35% or device therapy is not indicated or appropriate. And if the symptom persists, consider the therapies with the class 2 recommendations. Again, if the patient is in sinus rhythm and the LV ejection fraction is less than 35% and QRS is great more than 130, then we have to opt for CRTD. That is resynchronization therapy. So here ICD and CRTD. If the patient is less than 35% and QRS is less than 130, then ICD. And if the patient is LVEF is more less than 35% and QRS is more than 130, then CRTD and we have to choose. Next, to reduce the mortality for all patients, we have to use SE inhibitors, ARNIs, beta blockers, MRA, that is mineral like spironolactone and all, and SGLT2 inhibitors. Then To reduce the hospitalization and mortality, we have to do the diuretics, that is volume overload. We have to treat with diuretics. And if the patient is with the sinus rhythm with the LBBP greater than more than 150, then CRTP or D, and sinus rhythm with the LBBP 130 to 149 milliseconds, and non-LBBP more than 150 milliseconds, then CRTP or D. Then ischemic etiology, if it persists, then we have to opt for ICD. Then atrial fibrillation. If the patient is having atrial fibrillation, we have to go for anticoagulation. Then if the aortic stenosis is there, then we have to treat the aortic stenosis with TAVI. Then AC inhibitor or ARB is not tolerated, we can use the ARB. This ARB is angiotensin receptor blocker. Then for selected advanced heart failure patients, if the patient is not settled with all these treatment modalities, then we have to opt for heart transplantation, mechanical circulatory support. It is a bridge to treatment, bridge to transplant, or bridge to then long-term mechanical circulatory support is there. That is the destination therapy. You can use as destination therapy. To reduce the heart failure hospitalization and to improve the quality of life of all patients, we have to use the exercise rehabilitation and multi-professional disease management. So this is very important. This is the importance of heart failure nursing. Then if the patient is in acute heart failure, how will be the treatment? Then we have to assess the patient is warm or dry, warm and wet, cold and wet, or cold and dry. If the patient is warm and dry, then we have to do MSc oral therapy, and we can treat this in outpatient unit. So if patient is warm and dry, if the patient is warm and wet, warm means the peripheries are warm, and wet means the respiratory system is wet. I mean, it is wet in the sense it is congested lungs. So it is known as congested state. So we have to use the diuresis. The patient may need emergency department or inpatient treatment. If the patient is being cold and wet, cold means peripheries are cold and congestion is present, then we have to, it is known as decompensated. So here we have to, this is cold, peripheries are cold, so we have to use the inotropes. And the lungs is wet, so we have to do the diuretics. So vasodilators, diuretics, and inotropes we use here. Then cold and dry. In that state, inotropes, vasodilators, and patient is dry and cold. So it means the heart is not able to pump properly. So he may need mechanical support. Then acute heart failure, that is the worsening of the situation at any time of the disease. So here there will be a high risk for SES. You can see the resistance here. Yeah, according to the severity score, we have to treat the patient. Here we have to treat the IV therapy like the diuretics, vasodilators, and diuretics. And we have to monitor the dyspnea, SBP, the systolic blood pressure, the SpO2 heart rate rhythm, pure output blood perfusion, etc. And improve the symptoms, maintain the SBP in 90. Then, if the patient is settled, then we can shift the patient to the ward. Okay, and if the patient is settled again, we can send the home observation after 24-hour observation. And after reaching home, the patient has to visit the cardiologist within 1 to 2 weeks. And again, the palliative care is also can be considered. I'm skipping slides. You can see the initial stabilization in acute heart failure with the vasodilators, and then finding and treating the cause. So So we have to treat the cause like myocarditis. The patient is in myocarditis, we have to treat that. Then decompensation of a previous chronic heart failure, then accelerated hypertension, arrhythmias, pulmonary embolism. Then treating the precipitating cause like anemia, infection, arrhythmia, endocrine disorders, etc. So other aspects of drugs like fluid and salt restriction. Fluid has to be restricted. Fluid restricted like 1.5 to 2 liters. Salt should be less than 3 grams per day. Then inotropes again, we will use to start with dopamine. If the patient is BP is less than 85 and the patient is has a shock, then we have to start the dopamine. Then if shock persists again, we have to think about neuroprotective. Then mechanical circulatory support like ECMO and LVAD, etc. So the device therapy. So apart from this medical management, again the device therapy we already mentioned. That is, if the patient is in sinus rhythm and QRS duration is more than 150 milliseconds, then LBBB QRS patient is with the LBBB QRS morphology, the patient has to go for CRT, cardiac resynchronization therapy. You can see here if the patient if the EF is less than 35%, patient is on sinus and the LBBB is there, and QRS is more than 150, and class NYHA class is 2, 3, or 4, then we have to go for CR. Then if the LV is less than 35%, sinus LBBB 120 to 150 in class 2, 3, and 4, then again we can opt for CRT. So again, here we can see if the patient is in sinus, LBBB, CAD, then more than 150 class and NYHA class 1. So these are the chart we can see the indications for CRT. So this is very important. So if the patient is LV ejection fraction is less than 35%, even patient is in sinus rhythm and LBBB. LBBB means left bundle branch block, and QRS duration is more than 150. Then we can indicate the CRT is indicated. Then another thing is implantable cardioverter defibrillator. Cardioverter defibrillator is ICDs. ICD will give only defibrillation. There is no synchronization. In CRT, there will be synchronization. Synchronization between the atrium and ventricle. Atrial and ventricular synchronization will be there. So in ICD, it will give only the defibrillation. So ICDs are recommended to reduce the risk of sudden death and all-cause mortality in patients who have recovered from ventricular arrhythmia causing hemodynamic instability and who are expected to survive more than 1 year with good functional status and in the absence of reversible cause or unless the ventricular arrhythmia has occurred less than 48 hours after MI. So if the patient had a MI and he may develop he had developed the MI and he had developed the ventricular arrhythmia. So we can use this as a secondary prevention. Then as a primary prevention, here the patient had an MI within 40 days, we have to insert the ICD for prevention of the next arrhythmia diagnosis. Then the MCS, that is mechanical circulatory support. Mechanical circulatory supports are the mechanical devices which help for improving the circulation. So here the bridge to we can use this as bridge to decision, bridge to candidacy, bridge to transplantation, bridge to recovery, and as a destination therapy. So in various modes we can use, and the ventricular examples are ventricular assistive devices, then ECMO and ECMO. So here the LVAD. LVAD is nothing but this is a motor you can see here. It is placed in the left ventricle, and this LVAD will pump the blood into the aorta. So the left ventricle is not able to pump. So this motor will pump the blood into the aorta, and this LVAD controller will be outside of the body. So the patient can wear the controller here, battery here. So the patient will have three pouches here over the waist. So this is left ventricular assistive devices. So it can be used as a right ventricular assistive device again, and BiVAD in both left ventricle and right ventricle we can connect this together. So what are the indications for LVAD? LVAD indications are left ventricular ejection fraction less than 25% and unable to exercise for heart failure. And patient is not able to exercise, his ejection fraction is less than 25%. And the patient had more than 3 times hospitalization in 12 months. And he is dependent on inotrope therapy and temporary and progressive end organ dysfunction like hepatic failure. He is going into the hepatic failure, he's going into the cardiac asphyxia, going into the pulmonary hypertension. So this is an end stage like situation, and he is not able to get the heart transplantation also. So in that time, we can use this LVAD. It can be used as a bridge to transplant or bridge to destination therapy. We can use this as a destination therapy also, and bridge decision. So in various forms, we can use LVAD. Then comes the ECMO. ECMO, we know what is ECMO. ECMO is nothing but this is also similar to the LVAD, same mechanism, but the pump will be outside. So the patients, the from the vein, the blood will be taken, and it will go into from the vein. It will go into the motor. Like this is a pump. From pump, it will go into the lungs. It's an artificial membrane. So it is a lung. So from here there will be gas exchange, and from there it will go back to the patient body to the artery. So from veins to artery, VA ECMO. There are ECMOs in different type, VA ECMO and V ECMO. In usually the cardiac patients, we use VA ECMO. From the vein, we will take out the blood, and through the artery, we insert the blood into the body. So here the ECMO can be used as a temporary method. We cannot use keep patient in long term for ECMO. Then another thing is heart transplantation. Heart transplantation is the last option. So heart transplantation is we are changing the heart of the body. So we will replace the deceased patient's heart with the cadaveric heart with the living heart. So two types of transplantations are orthotopic and heterotopic heart transplantations are there. So some questions. So ICD, CRTD, and so this is the device therapies and mechanical circulatory support. So which of the following is primary indicator for cardiac resynchronization therapy, CRT, in heart failure? Left ventricular ejection fraction less than 35%, MHA class 3 and 4 symptoms, QRS duration greater than 150 milliseconds, and all of the above. Another question is, patient with a recent diagnosis of heart failure has been prescribed furosemide, that is Lasix, in an effort to physiologically do what for the patient. So what the Lasix will do? So it will reduce the preload, it will decrease the upload, will increase the contractility, and promote the vasodilation. Yeah, this is a summary of the treatment. So here we use the medicines like AC inhibitors, ARB, ARNI, then beta blockers, ibradine, then like complementary diet therapy also that I didn't mention. I mentioned like there should be decreased salt intake and fluid intake. Salt intake should be restricted to less than 3 gram per day, and water intake should be restricted less than 1 to 1.5 liters per day. Then diabetes mellitus management, CAD, vaccinations, then diuretics, vaccinations like patient, if the patient is getting influenza, then influenza vaccines are to be given. Then diuretics like loop diuretics we discussed, then exercise and rehabilitation, then failure of above, we have to do the transplant. So this is the ABCDEF of heart failure management. A for S inhibitors, B for beta blockers, C for complementary therapies, D for diuretics, E for exercise, F for failure of the above transplant. Then comes the, I'm going to discuss about the nurse-led heart failure clinic. So here I discussed more about, so far we discussed about the heart failure. What is heart failure? What is signs and symptoms, clinical, different clinical manifestations, classifications, and its management, then device therapy, medication therapy, and mechanical circulatory support therapies, transplantation. Now we are going to discuss about the nurse-led heart failure clinic. It is very important thing for the treatment of heart failure. According to the European Society of Guidelines, but the important characteristic component of a heart failure management program is a multidisciplinary team approach. So multidisciplinary team approach is what are the components of that is optimized. There will be lifestyle choices, pharmacology and devices, patient education, provision of psychosocial support. So follow up after discharge, easy access to healthcare, so assessment of unexplained change in weight, nutritional status, quality of life, sleep problems of the patient, access the advanced treatment options, supportive and palliative care. So these are the components of an ideal heart failure management program. So here, what we do in as a um, for giving a proper management, so we have to approach, we have to take a multidisciplinary approach where we can use different personnel from the different areas of the hospital. So multidisciplinary interventions recommended for the management of chronic heart failure. It is recommended that heart failure patients are enrolled in a multidisciplinary heart failure management program to reduce the risk of hospital HF hospitalization and mortality. The either home-based management or clinic-based programs improve the outcomes. So home-based management we have to do. That is, the patient has discharged from the hospital, he went out of the OPD, and we have to monitor the patient at home. So how we can monitor the patient at home? So that we have to think. Then here we can see the pneumococcal and influenza vaccinations. Pneumococcal and influenza vaccinations we have to do for the patient, because the patient will get, because the patient will already in the congestion, patient will have more sputum respiratory infections. So he is more able to more prone to get influenza and pneumococcal infections. So we have to give these vaccinations to prevent infections. So what is nurse-led clinic? This concept of nurse-led clinic actually came in 1980s in Sweden. So nurse-led clinic is nothing but a nurse will lead the clinic, and nurse will the crux behind this is to educate the patient and empower the patient. That is the main function of nurse-led clinic. The heart failure nurse is an important role within this multidisciplinary heart failure management program. What are the multidisciplinary team? There will be heart failure nurse, cardiologist, cardiac surgeon, nurses, laboratory technicians, pharmacist, dietitian, cardiac rehabilitation team, ECG and ECMO technicians, social workers will be there. So, what is the benefit of nurse-led heart failure clinic? So, it is like we are providing the knowledge to the patient. So educate the patient properly, because the patient needs more proper personal attention. Because each patient is different. Each patient will have different level of knowledge. So some patients are from low economic status, some patients are from high economic status. Their educational levels should be different. So they don't know what to do, what to don't do. So they don't know what to eat, what to not eat. They don't know how to do activities, what are the activities we can perform or not. So we have to educate maternal physiology. You have to educate the pathophysiology of the heart disease. So this is your problem. So you should not do this. You have to do this. We have to explain. We have to explain regarding the dietary management, lifestyle modifications, and medication adherence. Medication adherence is very important because if the patient, this is a chronic disease. Heart failure is not a acute disease. Acute decompensations will be there, but it is a chronic disease. So what will happen? The patient will not take medications for long time. He will take a day, then next day he will leave the medication. So what will happen? Ultimately, he will end up with the decompensation and he will admit into the hospital again. He will have more recurrent visits to the hospital that will affect their family system. That will affect their financial. That will give more financial burden to them. So all this will increase because of their improper management. What the heart nurse-led heart failure clinic do? We, the nurses, are educating the patients. So through the knowledge, we empower the patients, and we give more confidence to them to treat the disease. So through that they can self-manage this. Then again, the empowerment in the sense, this empowerment will improve the quality of life. Then again, this nurse-led will reduce the mortality. Again, reduce the prevent the progression of disease and reduce the healthcare cost and reduce the ED visits. And it improves the compliance to the treatment and improve the self-care behavior. So these are the advantages of nurse-led heart clinic. Then these are some studies which read about these benefits that reduce the cost and length of stay. Nurse-led clinic reduce the readmission rates. So it will reduce the readmission. So nurse-led clinic will reduce the mortality. Then okay, usually what will happen in hospitals when the patient admitted into the hospital, he came with the acute decompensation of heart failure, and he will be stabilized with diuretics or inotropes. Then again, additional medications he may get, and he may not get no additional education and no proper heart failure management will be there. So what will happen? They will go to the home after discharge, and again there will be no follow-up. The patient will not know what is, he don't know how to manage this. What will happen? No recognition of decompensation and lack of compliance will be there. So this will increase the decompensation and increase the hospitalization. So if the patient is not having proper education, the patient will get decompensation recurrently and he will end up with the multiple hospitalization. So what will happen in care pathway in heart failure clinic? So here, if the patient got stabilized, there will be additional medication. According to the guidelines, the patient will get the medication and education will be provided to the patient and patient relatives and he will send to home and there he will get good follow-up through phone or he will get helpline numbers. So through that he will get follow-up and there will be reduced decompensation and decreased hospitalization. This is the advantage of heart failure clinic. So how to set up a heart failure clinic? How to set up? If you are working in a hospital, you can set your own heart failure clinic there. You talk to a cardiologist. You can, if you are interested to lead a heart failure clinic, you can talk to a cardiologist. You can talk to him that you can work extra time, or you can, as part of your work also, you can do this. You get a permission from the management and get a cardiologist who is dedicated for caring the heart failure patients. Then motivate the nurses, fellow nurses. So you make 2, 3 nurses along with you and make a team and introduce about the concept of clinic to the management and convince a cardiologist and fix a one day clinic in a week. So all the heart failure patients can be referred to that area by the other doctors also. So you can give special attention to these patients. You can give more education to the patient, and you can keep a helpline number with you so that the patients can contact you. So this is how we can create a heart failure clinic. This is a simple technique you can make. You don't want to spend more money for that. You spend some time in a week. We can spend one day, and one day you can spend only 4 hours or 5 hours. That is enough. So what will happen in AIMS? What we did is we have initial assessment by the nurse. Then we shift the patient into the patient will see the cardiologist. Then there will be exercise training. We will teach the patient regarding the exercise. Then the patient will be provided with a Uday card, and patient will get yoga training. So in activities of heart failure nurse in a heart failure clinic, what a heart failure nurse do? The assessment and screening, filling the checklist. Checklist is to reduce the. This is to find out the flaws. We can find out if any mistakes is made by the patient, and we cannot do. We can find out through the checklist and exercise and yoga training. They can and docs to improve the medication adherence. Collaborate this with the social workers and physiotherapists. Then introduce the that can two mobile app, then providing counseling for the heart transplantation as per heart transplantation. This is the checklist we use to fill in the OPD. Here we can see the medication. We can see the status, whether the patient's status is improved or better or worse, and whether the patient is taking all the medications like A, B, C, D, vasodilators like SC inhibitors, ARB, RNA, isolazine, then B, beta blockers, evaporating, C for combined drugs, D for diuretics. So all these medications according to these guidelines, we are ensuring the patient is taking medications according to the guideline or not. Whether patient is skipping the dose, whether the patient is buying it or not. Sometimes the patient is from low socioeconomic background. They may leave to buy. They, they may not be affordable to buy the medication. So we have to take the proper history. We have to ask the patient properly, and we have to note it. Then we have to give the exercise training, and this is the Hriday card. Hriday card here also. I will show it later. What is Hriday card? This is the ABCD technique that we mentioned already. ABCD was this SE inhibitors, beta blockers, diuretics. We make it in different pouches and give. So instead of now we will explain the patient that A is for BP medications, B is beta blockers. They will not know the proper actions, but D can say this is a urine pill. If you want, if you have more weight in 1 week, you have more than 2 kg weight gain, then you can take this diuretics one pill extra. So that we can tell them to take one extra pill if the patient is having more congestion and the congestion symptoms or edema symptoms and the, so that we can educate them. Then this is the Dedcan app. It is a mobile app we use in AIMS that the patient and the doctor will use this app. Through this, patient can contact the doctors. They can exchange the informations like basic informations about their health. This is home-based management. So apart from this OPD, the heart clinic, we do this home-based management. We use this Hriday card. Hriday card is containing medication chart. So here we will write the medications properly. We will educate the patient by using these instructions. So some health informations will be provided in this card. Here we will divide the disease condition into three zones like red zone, yellow zone, and green zone. The red zone is what are the signs and symptoms of red zone, what will happen in yellow zone, what will happen in green zone, that will be explained, and what you have to do in this zone. That is also explained in this. Then what are the important instructions, like you check the weight daily, you reduce the salt and fluid intake, then do exercise, then fix the schedules, appointments, then do the yoga, exercise. So all these necessary informations we provide in this Hriday card. So the patient can take this card into the home, and from the home they can refer these symptoms, and they can understand when I have to contact a doctor, when I have to contact a nurse. So that we are clearly mentioned here. So the patient can manage their disease well with this card. And again, there will be a helpline number, so the patient can contact to the nurse, heart failure nurses through this helpline number if they have any emergency. Then teleconsultation during COVID time and all, we used to do this COVID consultation. The patient got consultation by sitting at home. So here the cardiologist will sit and give the medication, will give the instructions. Then the heart failure nurse will coordinate this process, and the cardiologist will do the consultation. Then that can through mobile application. Here again, I told the patient can enter their basic data here, and it will reach into the doctor side. Then inpatient service, heart failure nurse do the inpatient service apart from the OPD and home-based management. He will do inpatient service. Inpatient service like assessment, management of the patient with heart failure, inpatient teaching, and advanced heart failure management like transplant, LVAD, and ICD, etc. Then discharge counseling, counseling for advanced heart failure management, LVAD and ICDs, and post-discharge follow-up, etc. Then this is the ICU checklist the heart failure nurse will carry. This is the discharge checklist. So these are the checklists. Why we are using different checklists? Checklists are just to checklists are designed to improve the quality of the care. So we are ensuring whether the patient got proper care or not. So ICU checklist is whether the patient got proper care in ICU. Discharge checklist is during discharge patient got proper education, proper medications, proper treatment or not, that we assess in discharge checklist. Then self-management education. Here, the patient will be during discharge time. Patient will be explained about the medication compliances, then daily weight monitoring, then salt and fluid restriction, then activity and exercise, then alcohol and drug cessation, smoking cessation, then signs and symptoms of heart failure we explain. So these are the things we do. We are not the heart failure nurse are not teaching to the not only teaching to the patients but patients relatives bystanders. We are to teach them also. So the primary caretaker who is caring to the patient. So she or she should be educated properly regarding the patient's food, patient's activity, weight monitoring, exercise, etc. So this is the hospital quality improvement checklist we use in ICUs. Here we can see the IV inotropes, whether the patient is getting on any IV inotropes. If the patient is on inotropes for hypertension, decrease the urine output. Um, Initiate the IV inotropes if the patient is having less urine, and initiate the dopamine if the patient is in low BP. Initiate the dobutamine if the patient is normal BP along with altered LV function. Then AC inhibitors we can start initiated as soon as possible. So before that, the patient should be on diuretics. She should be on diuretics. It should be 2.5 times the home dose. If the patient is acute, patient is admitted in ICU with acute decompensated heart failure, then the diuretics dose should be 2.5 times the home dose. So and output we have to expect like more than 2 liters per day. So if the patient is on diuretics, then we have to monitor the electrolyte. So the nurse has to ensure whether the patient is on proper electrolyte monitoring or not. And then again, AC inhibitors, it has to be started as soon as possible. if the patient is weaned off from the inotrope, then as inhibitors will be started, and beta blockers will be started after the patient mobilized and is off IV diuretics and inotrope. Then anticoagulation. If the patient is on AF, then the anticoagulation is must. If the patient is bedridden, then anticoagulation is must. So low molecular weight heparin should be started, and oral anticoagulants should be started in mobilizing patient. Then other aspects like CAD. If the patient is on CAD, then you have to monitor the lipid profile. Then the patient should be on aspirin, like ecosprin and all. Then statins, patient should be on statins. Then if the patient is on DM, then we have to monitor the HbA1c. Then daily dietary modification we have to teach. Then endocrinology consultation. Then vaccination, if the patient is vaccinated or not. So influenza and pneumococcal vaccinations we have to provide. Then health counseling for the patient on ICD, CRTD, and if the patient is waiting for transplant, then we have to educate the family regarding the transplant. If the patient needs more social health worker, then we have to contact them also. So then arrange a follow-up after discharge, after 7 days of discharge. So these are the ICU monitoring sheet that we maintain in the ICU. So these are the checklist. This is another checklist during discharge. So we have to ensure the patient is getting proper discharge advice. The patient got proper treatment. So all these things we will assess in this discharge checklist. Then ECMO management, MCS, the mechanical circulatory support management. The patient, if the patient is on mechanical circulatory support, then we have to be very careful. We have to assess the ACTs every 3 hourly. We have to check the uh, PO2 values of this blood. All these things we have to assess. The proper monitoring of the patient should be needed during the ECMO. ECMO. Then ECMO patient management focus should be on hemodynamics, gas exchange, radiology assessment, anatropes, ventilation, sedation, nutrition, infection, bleeding, thrombosis, etc. Then prevention of complication in ECMO. That is also important because ischemia, thrombosis, bleeding, air embolism, blood formation, infection, thromboembolism, heparin-induced thrombocytopenia, neurological injury, renal dysfunction, all these things has to be considered. Then watch for ECMO emergencies like accidental decannulation, circuit ruptures, unintentional introduction of air bubbles, and circuit air embolism, oxygenator failure, cardiac arrest has to be checked. Then family counseling. Obviously, the family will be in the mental trauma, so we have to give them proper education. We have to give them proper comfortable management, teaching sessions, reassuring the members, consistent, constant updates we have to do regarding the patient, provide the opportunities to be with the patient. So these are the important aspect of ECMO management. So the heart failure nurses role in heart transplant process. What the heart failure nurse do in heart transplant. So in pre-heart transplant roles, the patient selection. So we have to do the proper selection. The right patient has to be selected for the heart transplantation. Then after selection, the patient should be listed in ORBO, follow up in a heart failure clinic. We are after listing in ORBO. ORBO is in India. ORBO is organ retrieval banking organization. So we have to list their name in the ORBO. Then we have to wait for the transplant. So before that, we have to do the follow up. Before transplant, we have to do. So there will be a waiting period of 6 months or 2 years will be there. So we have to do the follow up in between. So donor recipient size matching, ischemic time. Then comes the post transplant roles. After the transplant, there will be hemodynamic monitoring, management of acute post operation complications. Then post operative in the ward, when the patient shifted to the ward, there will be maintaining strict infection control practice, then family member education, mobilization, mobilizing the patient, then discharge counseling, home visits, home visits, Then long-term post-transplant, after the patient got discharged from the hospital after the transplantation, then again the long-term follow-up will be the telephonic helpline, weekly monitoring, blood investigations, echocardiogram, endomyocardial biopsy, CT angio, all this has to be performed. So we have to call the patients regularly. We have to fix the appointments. We have to make the rotatory, we have to follow up for all the patients. Then this is the post-transplant follow-up we use in AIMS. So here we mention all the investigations and necessary important medications like tacrolimus, Celstab, and all the immunosuppressive medications and these prophylactic viral prophylaxis and fungal prophylaxis and bacterial prophylaxis. All these medications we will maintain, and all the investigations like LFT, RFT, the level of the drug, this tacrolimus level, all this we will write, and according to these levels, we will adjust. The cardiologist will adjust the dose of the drug. Then LVAD patient management, again, if the patient is on left ventricular assisted device, again, we have to make the observation checklist. We have to educate the patient first. We have to convince the patient for LVAD, and immediate post implantation management. We have to do like patient family education, travel care, battery management, monitoring speed, PP assessment, warfarin dose adjustment, all these things we have to educate the patient. Then teach the patient and the family regarding the post-operative complications. Instruct the report the heart failure helpline. So we have to provide the helpline if any necessary. They have to call. Then heart transplant. After the heart transplant, we do all the follow-up and all. Then again, we engage them in different activities like heart transplant day celebrations. In India, August 3 is the heart transplant day. Then these are the 25th anniversary of heart transplant day was celebrated in AIMS in 2019, where all the transplant patients they play different games, and they had cultural events where they performed. So then organizing the heart failure nurses has to organize the CNEs, and they give the heart failure management updates and conducting the research activities. Then certification program for nurses, again, we conduct. So take home message is heart failure nursing heart failure is a complex disease. It is a complex syndrome. It has to be managed with proper medications, proper equipments like device management. Then again, we have to educate the patient. We have to do the mechanical circulatory support. We have to do then again medical management, lifestyle management, then dietary management. So this is a complex management process. So it needs a team of enthusiastic people, which contains nurses, again other department like physiotherapist, dietitian, then lab technician. So everybody has to collaborate and care for the heart failure patients, so that we can reduce the hospital admissions of the patient, we can reduce the mortality, we can reduce the healthcare cost of the patient. Already the patient will be in a suffering state, so we are giving a support to them by collaborating with different departments. So heart failure nurse play an important role in treating this heart failure patients. So heart failure clinic has to be implemented, has to be run in all over India. Different setup, we have to develop the heart failure clinics, and we have to generate the investors who are interested in treating heart failure. Thank you.
Hi, thanks for attending our webinar on impact of nurse-led clinic on heart failure. So I once again congratulate all the participants who has taken their time to attend the webinar. And once again, I would like to thank our speaker, Mr. Subin PD, and moderator, Sneha. So I just want to tell you, give you some instructions regarding the post-test. So you might be got the information during the session from the speaker and from the moderator. And I just want to emphasize that you can see the questions from the in between the webinar. In between the sessions, the speaker will be might be ask you the questions. You have to attend the question from there, and we'll be providing a Google sheet in the description box. You can use that to submit your answers, and make sure that you are attending at least 80% of the score to pass to get the certificates, and the certificate will be given to your registered email ID when you are at the time when you are submitting the post test. So make sure that you are not making any mistakes while filling the form. Write your complete name and make sure that there is no mistakes in your email ID. That will ensure us to make the certificate delivered to your registered email ID. So once again, I just want to thank you all, and at the same time, please support us by subscribing our channel and just follow our channel, and we'll try to post more and more webinars to enhance the clinical nurses. So once again, thank you all. Thank you.